Hey everybody, my name's Lisa. It's lovely to meet you all. I'm really honored to be with you here today. And I have to confess, there are more dentists and dental hygienists on this call than I thought. So I look forward to having their expertise make my slides look bad over the course of this talk today. I originally trained as a general dentist, and then I went back to medical school, and now I'm also a board certified internal medicine physician. I practice primary care here in Boston at Brigham Women's Hospital, and most of my time is spent as a health services researcher. And I'm really excited to get to be here with you all today. We are talking about responding and recognizing common oral health conditions. I kept it super common. There is nothing that is not like bread and butter stuff in this call, things that I as a PCP see a lot, and that many of you, I would imagine, do too, with probably varying levels of familiarity, perhaps based on what the extent of oral health access is like in your communities. So we'll just go through two quick cases. And I hope, not having been here in the past, I don't know what the situation is like when it comes to having this be interactive, but I would like it to be as interactive as possible. So please feel free to like shout out, and raise your hand. I'll try and monitor the chat for questions, but the goal is really to make this not just me talking at you the whole time. So today our learning objectives are going to be to describe common causes of dental pain, identify which tooth might be causing the dental pain, and then managing dental pain prior to dental referral. Because of course, probably the most important learning objective of this whole thing is that if someone is coming to you in the primary care office with a dental problem, that is already a sign that the system is not working for them, and your real job is to try and get them to a specialist, in this case, a dentist. All right, so chief complaint, my tooth hurts. And I'm just curious, is this something that people see relatively frequently in their practice, like in the urgent care setting or ED setting or primary care setting? I see some hands raised. Okay, I find it relatively common when I give this talk to providers here in Boston. This tends to be the thing that people most want to know how to manage. All right, so we are going to assume that everyone here is a great clinician, and we are going to do the sick, not sick thing. We're not going to get into the pedantics of like this patient that you are meeting with tooth pain does not have a fever. They are not tachycardic. They are not sick. They are in pain and they are miserable, and that stinks. So we're going to focus on that part today. But as always, I often say this, like use your medical brain when you hear about a tooth problem, because I think for many medical clinicians, the first impulse is, oh, I don't know anything about teeth. And we just freeze and we panic and we don't think about all the things we do know about, which I would invite you to do. So the first takeaway is let's not anchor. You're getting a lot of cues from the fact that this is a dental echo and that I am a dentist and that there are dentists on this call, that this is going to be a tooth problem. But let's pretend you didn't know that. And remember that tooth pain can be referred from lots of different places, right? So I think like the classic one that I see the most is someone who comes in and their chief complaint might be that they have a toothache. But if you ask them what tooth, it's really diffuse. They say like, oh, it's just everywhere. It's like all my top teeth right here. You may look at their mouth and the teeth look fine. And that's like a very classic referred sinus pain, which you can check for like having them move their head for positional tenderness or anything like that. Ear pain can localize to the teeth. TMJ pain, there can be soft tissue lesions, which we're not really discussing in this case because I would not consider them as common as caries, but are things that you should absolutely consider when you meet a patient. But again, we are keeping it super simple and bread and butter here today. So these are things you should think about, but we're going to say you thought about them and you know that's not what's going on here. Next slide when you have a chance, Jocelyn. Thank you so much. So this is what you do see. Is this normal or is this not normal?
Not normal.
Thank you. Thank you, Dr. Shakart, another dentist on the call, right? It's not normal. And I want to point out a couple of things that are going on with the caveat that this is like a classic iPhone intraoral photo that I get texted to me by my colleagues a lot. So a bunch of it is out of focus. This is not a global view of someone's mouth. This is not the beautiful intraoral photography I bet the dentist on this call can take, but we can still see a bunch that's going to tell us a lot about our patient. So the first is this tooth is broken. It's really broken. There used to be a lot more of it and it is gone. So sometimes that can happen in the course of trauma, but almost always when you see a tooth like this, it became undermined due to dental decay, due to caries, and then eventually broke in the course of doing its regular job. So this is almost guaranteed to be caused by caries, even if the patient comes to you and says, I was eating breakfast this morning and the tooth broke. That's the short-term story, but not the long-term cause. The other thing I want to call your attention to is this down here. Does anyone have a sense of what this is? underneath the tooth. I just realized you can't see my mouse, so that's probably not useful to you. I'm so used to driving my own slides. Yeah, so there's a big thing on the gums. Does anyone have a sense of what that is? Who's not a dentist? An
An
abscess.
abscess.
Yes, thank you so much, Dana. Yeah. So this is an abscess, which is just like a bubble of pus that has extended from inside the tooth down through the tooth roots and is basically looking for a place to go and creating a sinus tract into, oh, thank you so much, Jocelyn, into the gums. So I'm going to show you a couple different pictures of abscesses. This is a really classic one. You can see the pus inside of it. It's like a bubble. It looks very classic. Patients might even describe this to you. They might say they have a pimple on their gums, or we may see this actually develop a fistula, and people will say, I had a painful bubble on my gums, but now I have this little hole and I actually feel better because they're getting drainage. So depending on the time course, you can see a whole bunch of different things. The other thing I want to point out is here is this abscess, obviously no good. Here is this broken tooth, also no good. And it'd be pretty reasonable to think this broken tooth is causing the abscess. But that's not a guarantee because if you look at this very poorly focused photo, the tooth next door is also fractured and broken. So, 2 points there. One is it's not always a guarantee which tooth is causing the problem. And we'll talk about some ways to determine that or whether you might not even bother. But the other thing I want to point out is that when you look in someone's mouth who's coming to a primary care or other medical setting with a tooth problem, is they are very, very rarely going to come to you with one single broken, decayed tooth and a mouthful of otherwise perfect teeth. Because remember that coming to you instead of to a dentist is a demonstration that the health system has failed them and they don't have dental access, which often means that they have lots of untreated dental disease. And this is just the thing that's bothering them most in this moment. So this abscess could be coming from either tooth, but also I wouldn't be surprised if many of the teeth we can't see in this photo are also decayed. So does anybody have any thoughts for what they might do to pick which tooth is causing the problem? Which of these two teeth?
Do you want the
X-ray?
dentist or the
Yeah.
non-dentist?
I want non-dentist. Dentist, you're gonna make me look bad. You're not allowed to talk yet. But I do see
X-ray.
someone say
X-ray.
X-ray, which is a great point. And I'm gonna qualify that and say, yes, thank you so much, Heather. You're allowed to say it then. You're allowed to say X-ray. And I think some practices who see this a fair amount actually do have appropriate dental X-rays for doing this kind of work. You would need a really narrow scope, small dental X-ray to capture this image. Or in some cases, I've seen a panoramic radiograph, a Panorex machine in like EDs and things like that, which would be another reasonable option. But I also see a fair amount of inappropriate imaging for this kind of thing. I remember that I got a page, like an actual page on my pager from a mentor because he was seeing a patient in clinic with a toothache and he wanted to know if he had to order a CT face. A CT face is a huge amount of radiation and like several $1,000s. This patient should not be getting that kind of imaging because if you see it, what is it going to show? An abscess, which you can see in the mouth. You know it's not affecting the patient's airway. You know they don't have a systemic infection because they don't have a fever and they're not tachycardic. So there's very limited utility to that imaging. And if you brought that CT face to a dentist, they would not use it to drive their treatment plan. They would take a dental radiograph. So I would actually encourage you not to get too much additional imaging unless you are lucky enough to have access to appropriately scaled imaging that might exist in a dentist's office or in some really well-resourced settings. I'm going to tell you some other really low-key things you can do. You take your glove finger and you can push on the gums like this near the teeth. Sometimes, obviously, there's an abscess there. Don't push directly on that. We're not cruel. But sometimes you might feel a little bit more fluctuance or a little bit more mobility of the teeth based on which one is more infected. You can also take a tongue depressor and tap on the teeth. You can percuss them. The one that is more sensitive is because the periodontal ligament, those like little fibers that hold the tooth into the bone, are getting stretched out by the pressure from the abscess. If you tap on a tooth and it's very, very sensitive, warn your patient before you'll do this, by the way, that is more likely to be the tooth that is causing the infection. This really helps because it can make your note look super smart and impress your dental colleagues. But if you don't know, that's also okay because it's not actually going to change your management in this moment in your office. So if your options are to figure it out by torturing your patient, like if someone really can't tolerate this exam, I would say that is okay because you won't be the one providing definitive care. All right. So speaking of looking really good to your dental colleagues when you write your referral note, this is how we number adult teeth. Pediatric dentition uses letters. It gets really confusing. It's confusing for dental students too. I'm sorry if you also treat children. We're going to talk about grown-up teeth today. Everybody has all 32 of their teeth. I hear you. You're saying, I had my wisdom teeth taken out when I was a teenager. And I will tell you that you have four ghostly wisdom teeth that live in the mental map of your mouth. And those teeth are always going to start at number one. So in the upper right-hand corner of your mouth, that is tooth number one, your back wisdom tooth. Even if it's not there, you would just be missing number one, but it still gets that designation. You go all the way around the front of your mouth and then down like the face of a clock. So 1 through 16, down to 17, and around to 32. So does anyone want to say what tooth number this tooth is? You get so many points for being brave enough to guess. You do not have to get it right. Left lower, because that's beautiful. I honestly can't even tell from this picture if that is correct, but I think you narrowed it down enough. And I would say that this is probably 19 or 20 if I had to guess, but it's definitely 19 or 20. I can't tell which one it is. So again, if you put that range on there, maybe I'm not speaking for all dentists, I'll look for some nods, but I think I would be pretty impressed if that made its way to my office, like with a, tooth number that was not in the totally wrong quadrant. So just a way to kind of nail your exam and document the way dentists document. This also helps, by the way, if you ever read a dentist note, now you know what they're talking about. All right, we're going to take a tour of some other abscesses just to point out that that one is like really obvious, but they don't all have to look that way. So again, this one might seem really obvious too, right? There's this big deformity. It almost looks like a circle in the middle. So this is an abscess though, where you can't see that real change in color that we noticed in the previous image. So then we'd have to use other exam skills than just visualization to know it's there. Obviously, the easy thing is someone might come in with pain, right? That's going to cue us in a lot and help localize it for us. But this is where palpation, where we're going from hard bone to this like giving area of fluctuance, can be really helpful. And where if we're, say, deciding between these two teeth, which honestly look pretty good, which one is causing this problem, looking for mobility or sensitivity to percussion could really be helpful there. Here's another really subtle abscess. I would venture to guess that if there wasn't an arrow there giving you a giant hint, you probably wouldn't even know it was there. So I show this for two reasons. One is because it's always useful to use other tactile skills like palpation, percussion, etc., looking for mobility when you're checking someone's mouth when they have a toothache, but also because this patient could come to you in acute dental pain with a toothache. And if you didn't look carefully, you might even label this someone as someone who's drug seeking or inappropriately seeking care or even like falsifying their pain. And it's really important to believe our patients, validate them, and do a thorough exam. Here's another little abscess. You can see here it's a little bit whiter, which kind of gives you a hint that something is going on, but it's a lot more subtle than that first one I showed. So again, using other exam skills, including having the patient point out what's painful to them, can be really helpful. The other thing I'll mention is that, do you guys see this kind of like extra white little C shape on the top of the tooth right there? I know you can't see my cursor. That's actually a tooth colored filling or a composite filling. So that's decay right at the sort of, we call it the cervical aspect of the tooth, right near where the gums touch the tooth. And that tooth colored filling probably matched the color of the tooth better in the past. The tooth continued to like discolor from our lives drinking coffee and soda and stuff. And the tooth colored filling stays the same color, but that's what that is. And parenthetically, the tooth in front of it is probably a crown. But we're here to look at the abscess. And this is what an abscess looks like on a dental radiograph. So like I mentioned, dental radiographs are teeny tiny. They represent essentially like a null radiation exposure, and they get the detail that dentists need for treatment planning and diagnosis, which a larger, sort of less refined imaging modality that we often have in medicine wouldn't necessarily do. So I'm going to try and use my words because I realize you can't actually see my pointer. I'm going to do my best to paint this picture. You can probably see on the back of this tooth, there's a big white blob. That is an attempted amalgam restoration. Amalgam is made of metals, and so it bounces all the x-rays back towards us. But you can probably also see that kind of at the tip of that big white blob, there's almost a triangle of black. And that's because it wasn't a perfect filling and new decay came in right in that little leaky bit on the very back of the tooth. Decay starts out in the enamel. When it's in the enamel, we don't even necessarily need to do a filling. It's reversible. Then it goes into the dentin, which is the inside part of the top of the tooth. Dentin is still stronger than bone, but it's weaker than enamel. And once decay is in the dentin, it tends to spread faster. decay in the dentin results in a tooth restoration, like a filling of some kind. If the decay continues to spread, it enters this sort of darker part in the middle of the tooth, which is the tooth's neurovascular bundle. It has a nerve, an artery, and a vein. In dentistry, we call it the pulp, which sounds very silly, but that's what it is. When you have infection from the caries in the pulp, you have a toothache. Once someone has a toothache, they have infection in the neurovascular bundle inside the tooth. A filling cannot access the neurovascular bundle inside the tooth. So if somebody is coming to you with a toothache, it means they need either a root canal or a tooth extraction. Fillings are off the table. I think this is probably one of the highest yield things to be able to know because it really affects your counseling. This is about expectation setting, especially when root canals are not covered by many state Medicaid programs or might be out of reach financially for a lot of our patients. So, giving people the expectation that this tooth may not be restorable and not making promises that make it really tough for that patient to trust the dental provider they're going to have is really helpful if you're that person's trusted clinician. So we have the pulp inside the tooth with the infection, which will then also travel down the roots of the tooth, which is where the nerve and the artery and the vein come in, and end up at the tips of the roots. So this black spot right here is essentially focal osteomyelitis at the tip of a tooth. That's what the abscess is. Even if there's no indication in the soft tissue, people can still have an abscess. It's just still fully contained within the bone. Once you're seeing it in the soft tissue outside the tooth, that's because it's spread enough that it's looking for a way out. It's spread into the soft tissue. All right. And this is something that I have never seen clinically and hope never to do so, but is probably going to be useful to you for boards questions. And I think also gets at the heart of this like sick, not sick concern, right? For the most part, if you see somebody with a toothache, they're going to be miserable and they deserve your care, but they are not sick in the classic sick way where we are worried. This is the exception, which is Ludwig's angina. And maybe some of you guys can identify from the title above. This is a New England Journal of Medicine photo, so you can tell it's considered interesting enough that NEJM wanted to publish it. Ludwig's angina is specifically when a dental infection, usually from mandibular molars, extend into the fascial spaces around the airway. This can cause a lot of problems, and you can see that this is causing this like widespread infection in the patient's chin, in the patient's jaw, and down his chest. It can extend into your mediastinum. But the really urgent, scary thing about it is that it surrounds the airway circumferentially and can compress it. So what we are worried about when we see someone with possible Ludwig's angina is airway compromise. This is why this is a surgical emergency. People with Ludwig's angina, often like this gentleman does, kind of have enough swelling that they almost have like a bullfroggy kind of look. They probably have trismus because all of the inflammation here makes it hard for them to open their jaw. They may be tripoding or not able to swallow any of their spit because their airway is getting so narrow. These are people that look sick. It is scary to see one of them. They need to go to the emergency room and be seen by a surgeon. But almost everybody that you ever see for a toothache will not have this problem. And their problem is still really important and is still something that we need to address. All right, so I gave away the answer a little bit on the imaging question, but would you get any labs for a patient who comes in with a toothache?
It depends if they look toxic or not. I mean, if it's just an abscess and you're going to take an x-ray and they're otherwise looking okay, febrile, then no, probably not.
What would you get if you were getting something?
CBC, sed rate.
Yeah. And would that drive management? Like, would you change your decision making based on that?
I'm not a
Yeah.
dentist, so I would refer to you. No, it would not
Yeah.
change my management.
Yeah. So this I think this happens a lot. I think it guides our self-regulation. Like we feel better having more information, but it probably doesn't drive our management. So I like the point you said, like if they look toxic, right? Like if this is going to be a decision point where we're worried if we want to like admit them or something, like that is one thing. But for the most part, and you said this too, like for the most part, this is probably not information that will change what we do because so much of this becomes essentially a structural navigation issue with some like mild management kind of tacked onto it. So I would say that if you are generally totally okay not getting any additional labs and imaging, unless you're well equipped within your institution to like use those things to directly drive care. I also say that I see this all the time. Like I rarely see a friend who has texted me about a patient in their urgent care clinic with a tooth problem without the CBC having already resulted. Usually is normal. So I think it's a hard habit to break. So we're going to talk about current guidelines, and then I'm going to get a little bit heretical and talk about why I don't think you necessarily need to follow these all the time. So these are brand new, hot off the presses guidelines from the American Dental Association. These are, and they're literally intended to be useful to apply to patients who cannot get to a dentist right away, which is, I think, a really laudable thing, right? Like these are clinical guidelines to help support what's identified as a huge gap in care. Um, so the two big things are it's that people can't get to a dentist right away, and they don't apply to people who can get to a dentist right away and are about to get treatment, which I think is great because also there are issues with dentists like waiting for patients to have their pain relief before they'll give them definitive treatment. And I think it's important for the ADA to say, like, do not do that. But the reason I don't put as much stock in these recommendations is because these are the three groups of diagnoses the ADA thinks this applies to: reversible pulpitis, symptomatic irreversible pulpitis with or without symptomatic apical periodontitis, or pulp necrosis with symptomatic apical periodontitis or acute apical abscess. And I'm going to ask if anyone who's not a dentist knows what any of those things mean. I, yeah. So these apply to dental diagnoses made in dental offices. So while I'm not sure that was entirely the ADA's goal, I would emphasize that while these can have some good learning points for all of us in any care setting, these are recommendations for dentists based on how dentists diagnose. And if you are in a setting where there are fewer resources, or you have fewer diagnostic abilities, or your patient cannot get care for weeks or even months because you are not a dentist, these don't necessarily have to apply to you. They are not guidelines for you. They can be helpful recommendations. So first, there are some about pain relief. And these are the basics that I would assume many of us are already following. The first is that we know that the combination of NSAIDs plus Tylenol works more superior to either alone. NSAIDs help with local inflammation. Tylenol helps with central interpretation of inflammation. Together, they're as effective as something like Tylenol number three. The other thing I would emphasize is that short-term elimination of that pain cycle is going to get you so much more bang for your buck for prescribing some of these over-the-counter pain medications. If someone comes to you with a rip-roaring toothache and you send them out with an ibuprofen prescription, like that's great, you did something appropriate, but it's probably not going to make them feel very much better. If you send them home with a numb tooth, they're no longer in pain, and you tell them to start taking standing ibuprofen Q6 hours, they are going to feel so much better, and that pain control will last longer. So if you can break the pain cycle in your office, which I would encourage everyone to learn how to do, that I think is the real ticket here, is something like local anesthesia. And I know, I'm sure some of you are balking at this. The last time I gave this presentation, I had the head of internal medicine at my hospital ask me if physicians were credentialed to be able to do local anesthesia, which is hilarious because like we are credentialed to put needles in people's like veins. Like we are credentialed to put needles in many other spaces where they shouldn't be and that are much more risky. But this one was like the one that broke the camel's back. So I don't have any slides specifically on learning local anesthetic technique. I think the best way to do it is to shadow a dentist buddy if or an RDH buddy if you have one of those or if this is of interest to you. I will also say that there are a great many very useful YouTube videos, and that if I ever meet any of you in person, you're welcome to practice on me because there is essentially no risk of complications. There is nothing vascular in most of the spaces you'll be going. You'll just sound bone and then have to retract a little bit. But as an internist, I think there are so few things that I do on a daily basis with my patients that actually make them feel better. Everything is like the long game. This thing makes people feel better. You will feel amazing after you do this because seeing someone walk in pain and leave with relief is astonishing and very easy to learn. So just putting in a plug for that. And then, of course, obviously the ADA appropriately discourages any sort of opioid prescriptions for pain control. I do not think these are generally indicated. But again, taking a more loosey-goosey approach to who these recommendations and guidelines are for, if you have a patient who's already on opioids for some reason, or who is taking buprenorphine for opioid use disorder, or who otherwise might have needs pertaining to opioids, I don't think it is an absolute contraindication to give them additional opioids if that is the pain management that they need. This is about like trusting yourself as a primary care clinician and your relationship with your patients. All right. Moving on to more heretical recommendations. This one's a little bit older, but these are the ADA's guidelines for using antibiotics for dental pain and swelling. And I'll also note that this was endorsed as well by ACIP, the American College of Emergency Physicians. but I still don't think you need to follow it, and here's why. So again, instead of prescribing antibiotics, dentists should prioritize dental treatments. And you know what? I agree with that very strongly. I think that's really important. Dentists should not meet a patient who needs definitive management, which is essentially surgical source control, and give them antibiotics. But this is not a recommendation that specifically applies to you as a physician or an advanced practice practitioner meeting a patient who cannot get to a dentist for an indeterminate period of time, for whom we are not going to consider antibiotics as part of a infection control procedure. I invite you to think about antibiotics in that scenario as pain control. Remember, we're not getting surgical source control. It's not in our scope of practice. But if we can shrink the infection to make it bearable during whatever period of weeks to months it takes for people to navigate to a dentist, that is a useful application of antibiotics. So correct. Antibiotics would be very indicated if someone was sick, if someone had evidence of systemic spread. And dentists should not be treating things that they can treat definitively with antibiotics. But I would say that this guideline leaves open a lot of leeway for those of us who care for patients who can't get to a dentist yet. So while they recommend to not prescribe systemic antibiotics as an adjunct to definitive conservative dental treatment, the certainty of the evidence is still very low. And again, this is an adjunct to definitive conservative dental treatment, not to waiting 2 months for your patient to get to a dentist, which is, I think, the situation that many of us find ourselves in with our patients. When it comes to antibiotics, it's super simple. Penicillin V, there's like literally no resistance to any oral bacteria. So you can use penicillin V, which apparently some pharmacies don't even stock anymore because it's so old school. It's annoying because you have to dose it QID. So a lot of people will use amoxicillin instead. You do not need to use augmentin because you don't have any resistance. So just plain old basic amoxicillin. If people have allergies, the third line is clindamycin, which obviously is not without risks. So, be a little bit thoughtful in that, but can still be very useful to your patients who need pain control. So I'll get off my soapbox, but here it is rephrased one more time with some of the things that you can use. Dental infections don't have any resistance. They're polymicrobial. You're not going to find a causative agent. You don't need to culture the abscess, which is something I've seen people do. Super impressive if you do, but it's going to be polymicrobial and it's not going to guide antibiotic selection for the most part. But penicillin V or amoxicillin will do just fine. So here's my personal recipe for how I manage this. The first is to eliminate the pain cycle by giving the patient a dental block. I'm sure all of your practices have 2% lidocaine lying around. We can get into the nuts and bolts of like specific favored kinds of dental anesthesia and whether there's epinephrine or not in them, or whether you need to worry about having epinephrine or not in it. The short answer is you don't need to worry. It is safe and fine. If it's in there, use it. If it's not, don't worry about it. But give a dental block. Your patient's going to think you're the best person ever. And then you can send them home with over-the-counter ibuprofen and Tylenol. People have different preferences for whether these are staggered or taken together. I think to a certain extent, it's a placebo effect, like not the actual inflammation, but like how often people are taking pills and whether they feel like that's like attentive to their discomfort. And then again, that amoxicillin or penicillin V is going to shrink the infection enough that I often counsel patients that they can expect between 4 and 6 weeks of pain control until they can get to a dentist, which at least in my area is often not enough time for them to get to a dentist, but is better than nothing. Two things there. One is that you have to remind patients, as you should remind yourself, that if they're coming in with a toothache, they need a root canal or an extraction. So if they feel a ton better on the antibiotics, you made them feel so good, they still need to go to a dentist because they still need a root canal or an extraction. So much of this counseling is about expectation setting, right? This patient needs to go to a dentist no matter how much better they are feeling. We have not fixed the problem. It is not in our scope of practice to fix the problem, but to palliate it and to work with our patient on how to get them where they need to go. All right, that is it for our excellent management of dental pain. Does anyone have any lingering questions or clinical things that have come up for them with this sort of thing?
I might just add a story about Ludwig's angina. The only time that I've seen it was in a teenager, actually, and it was related to impacted wisdom teeth, third molars on the bottom. And both of them were impacted and affected by really poor oral hygiene, and came in with the description of it feels weird when I swallow. So immediately, right? Like you're thinking that it's more than just a tooth related issue. Um, but the examination under the tongue was the only area that you could visibly see the swelling. You couldn't see anything externally. But yeah, like sent to the ER for, further treatment after that. But young people too can suffer from it, even though they're relatively healthy.
That's a crazy story. And also, I appreciate your point that doing a thorough physical exam is really important because you may not get that like perfect boards question like tripoding person.
Lisa, do you want to say anything about paresthesia as a risk since a primary care provider may be counseling this patient, or giving them a block? And the reason I bring that up is because I have seen maybe a handful of cases of paresthesia in the years that I've been practicing, and I think all of those cases, maybe except one, it was subsequent to some sort of dental infection. I don't know that that's necessarily related, but since when we give anesthesia, that's often something that we mention as a potential risk or side effect, whether it's permanent or temporary. So do you want to maybe mention that a little bit just as a awareness for the primary care providers?
Sure, super important point. So paresthesia meaning some possible nerve damage, which can lead to like tingling and weird sensation. Often a classic is like third molar mandible, like third mandibular third molars can cause issues with the lingual nerve, which runs right here, and people can get chin numbness. It's chronic. But depending on where you are aiming your needle and which nerve you are specifically going for, you can also cause paresthesia that may last as long as the anesthesia does, or indefinitely, depending on the extent of the nerve damage. Obviously, counseling your patient for risks and benefits, which is something we do for all procedures, is super important. And I would consider the risk of this like way, way lower than the risk of many things that we do in office all the time, like a corticosteroid knee injection or something like that. The other thing that I often recommend to people, especially if they are kind of learning this on the fly rather than through some more formal training, is that you can do very little wrong with local infiltration. So if you want to get super fancy or you happen to be a dentist, we know facial anatomy, we aim for specific nerves. Specifically, the mandible is very thick. It is cortical bone. It is hard to get to the nerves that feed the teeth there. So often we do what's called an inferior alveolar nerve block, which is the one where you open your mouth really big and you go back there. Maybe some of you experience this. And you can learn that. It is technique sensitive, but not hard. But if you are doing this for the first time, there is nothing wrong and essentially zero risk of just taking your needle and aiming at the apex, like the tip of where you think the tooth that's hurting is going to be. This will get you very far, especially in smaller people. So, children, smaller adults, you can do that almost anywhere in the mouth. And even on bigger people who might have thicker bone, this can still go a long way. So that is the thing I would almost always try because even if it doesn't work, there's essentially nothing there to hit. There's just some gingival tissue and then the bone protecting you from mucking anything up further. So that is also a way to kind of mediate some of that risk if you're feeling less confident in your technique. And also don't infiltrate your anesthesia directly into an abscess. That will lead nowhere good. So hopefully you know that from other abscesses in various locations in the body. So
I might also just comment for the primary care providers out there that as a dentist, it is super helpful if your patient that has an abscess comes in and they've already done a few days worth of antibiotics because it makes our anesthetics work so much better when we're then trying to extract the tooth. Like if their tooth has not had any antibiotic treatment, our anesthetics are in a pH that they're not very effective in. Whereas if the infection is treated even just a little bit, like 2, 3 days with an antibiotic, we get much better success with anesthetics. At least that's been my experience. So I do appreciate that.
yeah, that's totally true. And another strong recommendation for giving antibiotics despite the guidelines I shared that you shouldn't, that I don't listen to. So thank you for supporting me in that, Jamie. I feel better knowing another dentist doesn't think I'm a villain for suggesting it. All right, so we'll talk briefly about the chief complaint, my gums bleed. And this is really just going to be some images to kind of look at normal, not normal. And I'll say, like, I don't actually think this is a particularly common chief complaint. And I think there's kind of two contexts in which it's come up for me. One is people's gums are bleeding, they have periodontal disease, and we will talk about that. But the other one is like, again, remembering to use your medical brain and not to anchor, is that this does make me worry about coagulopathy. So whereas before I said don't get no labs, you don't need it. This is something where, especially if you're looking in the mouth and you're not seeing like an obvious reason for someone to have severe gum disease, getting a CBC at the very least would be completely appropriate to me because it's cheap, it's easy, and you're at the very least ruling out some really serious stuff, like classic for what should be, coagulopathy of some kind, leukemia of some kind. Those are two that kind of come up the most. So here is some healthy gingiva. You can see it's like a nice healthy pink. Sometimes we talk about the orange peel texture, which is that kind of that like nubbly, bumpy texture right on the gums above the teeth. I feel so silly saying this to someone who's a periodontist. I'm just gonna like totally like fall on my face on this one. But whereas podorange is a bad thing in other parts of the body, it's good here in the mouth. You can see that there is a wide variety of melanation in gingival tissue that is completely normal, does not require any treatment. And some cultures actually have beauty standards that favor darkened gingiva and actually include gingival tattooing. So most colors are not things we're going to look for as indicators of health or unhealthy gingiva. We're going to look for other things as well. And these are also beautiful teeth, very straight, very healthy. This is gingivitis. So with gingivitis, you're going to see inflammation of the gums. It's going to be boggy and swollen and very friable, easy to bleed, but it's not extending into that periodontal ligament or the bone that attaches to the teeth and keeps them in place. In many cases, this is not something that would be easy to identify in the primary care office. So where it comes to gingivitis versus periodontitis or what level of attachment loss someone has, I would say kind of like to a certain extent, you don't need to worry about that. But identifying that something is going on is really helpful. So things we can see. The patient in the upper right that has like almost like a really kind of puffy form of gingivitis. Sometimes this can be medication related. So like the classics are calcium channel blockers, some anti-epileptic agents. Actually had a patient who caused this on nifedipine and he ended up taking half a dose instead and it went away, which is not what I'd recommend necessarily. Some people, if the medication is highly necessary, like it's the only anti-epileptic that works for them, they might get intermittent visits to a periodontist to trim the excess gingival tissue. But that can also make it very hard to clean your teeth. And then you have this bacterial biofilm on the teeth that irritates the gingiva and makes it kind of a vicious cycle. But for many people, it's just a matter of making it very difficult to clean the teeth or just not having particularly strong hygiene. And that leads to that kind of irritation around the guts. So again, not extending into the bone, not causing the teeth to become loose, but this can cause a lot of bleeding. I've had several adolescent patients who told me that they woke up with blood on their pillow, which is a very alarming thing to hear as a physician, but was because they just weren't brushing their teeth. Other things that can contribute to this, like if someone has poorly controlled asthma or is using a rescue inhaler very frequently, that can increase kind of the dryness of this area of the mouth and make the gingiva more irritated and cause more bleeding. But a lot of it is related to oral hygiene. You can see that even if you like touched some of this gingiva, one, it would be very sensitive, and two, it would bleed a lot. This is something that is completely recoverable with treatment. That treatment is really careful and meticulous oral hygiene. Some of this is professional. We would call it oral debridement. We'd take like little tiny knives and just scrape all the gunk off the teeth, which would allow the gingiva to heal, but also having really good in-home hygiene to prevent it from building up again, which can be a hard sell because you're telling someone with gums that are really painful and bleed all the time that they need to do something twice a day that's really painful and makes their gums bleed all the time. So patient education matters a lot here. And here we have some periodontitis of various kinds. And the big picture is that actually in some ways these gums look better, right? They're not as big and rolled and puffy and bleeding, but you can see a lot more of the tooth. So this is the extent of the periodontitis where one, people might start to notice their teeth are loose, or even if they don't feel loose, they might notice that they've started to move or splay because occlusal forces over time are making the teeth move in a sort of unnoticeable way. You can see more of the tooth. Someone will look more long in the tooth. And the infection is spread so that without additional treatment that often requires dental anesthesia, a patient can't treat this at home. No matter how well they brush, they can't get a toothbrush into that area where the bone is infected with this infection. So you can see in the dental x-ray, there's big pockets of area where there should be bone to hold the tooth in place, and there isn't. This is really hard to show when I just taught you tooth numbers and also I can't use my index rather than my pointer. But you can see maybe between the two teeth, one is a mandibular molar and one is a mandibular premolar. There's almost like a V shape that's dark, and that's all bone loss. That's inflammation caused by bacterial infection and calcification on the tooth root itself, causing bone loss and mobility. This can be halted, but it can't be reversed. So once this is happening, the goal is to keep as much bone as someone has because we can't make them grow bone back, which is also why preventing it in the first place by counseling people about gingivitis is so helpful. I see a question, is gingivitis transmitted to toddlers by their parents? This is a great question. We have more than 1,000 species of bacteria in our mouths, and much of what becomes the normal oral flora is passed on to us vertically, often at birth. So there's even interesting studies that show that babies that were born via vaginal birth are less likely to have tooth decay than babies that were born by C-section, because like that process of like being exposed to the mother's vaginal flora also causes oral colonization and like the process that makes our happy ecosystem. When it comes to things like gingivitis or periodontitis, it's a little bit different than something like caries, which is like an obviously pathogenic bacteria that eats our sugar, turns it to acid, and makes holes in our teeth. So gingivitis can be caused by a multitude of bacteria, and I really think about it more as like a shift in the ecosystem. So they have like names for these complexes of bacteria that are good and bad. Red complex is like the most causative of periodontitis, but many healthy people have these bacteria in their mouth too. It's a matter of a local environment that makes it possible for these bacteria to proliferate. So I would consider periodontitis to be less of a transmissible disease than dental caries is, even though in theory they're both caused by bacteria. This is my last slide, and then happy to answer more questions, of course. So key points. A toothache needs treatment with either a root canal or an extraction. A filling will not be enough. Antibiotics and anti-inflammatories can temporize and relieve suffering for patients until they get to a dentist. Imaging and lab work is generally not necessary. And a patient presents to us in the medical setting with a dental problem because the healthcare system has failed them. So our real responsibility is to understand why they can't access a dentist and help them and enable them to do so. Thank you all so much for your attention, and thanks to the dentist in the room for making this such a richer and more thoughtful presentation. I'm so like honored to get to learn with you today.
Okay, thank you so much. This was fantastic. Does anyone have any other questions for our presenters or panel? Love to hear your thoughts and questions.
Could you explain a little bit about when you see an oral lesion, whether it's pigmented or even non-pigmented? What's the process as far as patient might not have known it was even there, so you don't have any idea of how long it's been there. And I always kind of get confused on, should we wait? Should we look at it again in 2 weeks? Should we refer? Just some ideas on lesions, oral lesions.
Yeah, this is a great question, and something I had on the presentation and took out because I wasn't sure we'd have time. So I'm so glad you brought it up because I'd love to talk about this. I think one thing is that like lesions can look like anything and still be oral cancer. Like they can be red, they can be white, they can be pink, they can look like nothing, they can be melanated. So while it can be helpful to know what like the good things or safe things look like, which are things like knowing what an amalgam tattoo looks like, knowing what a palatal torus looks like. These things where you're basically not going to end up with egg on your face for referring to someone who has a variant of normal in their mouth, or like knowing if people have like bilateral white lines from bruxism, like that is not oral cancer. But anything else that looks funky, like I think no one should ever shame you for referring or seeking out a biopsy. Like I think it is almost always appropriate to biopsy, and oral tissue heals really quickly. So it's a super easy procedure for the patient to recover from too. The general guidance is if you see something and you don't know what it is, it looks weird, have them come back in 2 weeks, and if he's still there, then you refer for biopsy. I think you can take that with a little bit of a grain of salt, depending on what sort of structural barriers there are to getting biopsy for your patient. So like in my clinic, it'd be really hard for me to see a patient again in 2 weeks. And there's also this element of if you refer them and they get to the biopsy and the biopsy's in 2 weeks, if the lesion's still there, they'll biopsy it. And if it's gone, They won't get it biopsied. So I think it depends in part on knowing your system. And to Jamie's question about where to refer oral surgery ENT, this is a similar infrastructural or like systems-based question. And it really depends on knowing who's going to do it faster and what resources your patient has. So even general dentists can do oral biopsies, but they will bill to dental insurance for this. So if your patient has dental insurance, that's okay. But for some patients, that might actually be financially catastrophic. Sometimes it's easier to refer to your patient, like I'm an Epic. If I want my patient to go to ENT, I go click, and they go to ENT, and within 3 days, they'll get a phone call that will schedule that visit for them. That doesn't mean that's the best place for them to go, but it's certainly the most frictionless for me to send them there, and that can matter for a lot. Generally, derm gets very fussy about doing anything that's beyond the vermilion border, which is like the part of your lip where it goes from being dry to wet. So sometimes you'll get a dermatologist who's game if it's like really close, but generally, like a thing on the tongue is something that will spook derm and they will not do it. If you have oral medicine or a student dental clinic in your health system, like that is going to be a great place to send people. And if you have oral surgery, that's similarly somewhere who won't bat an eye at like almost anything you ask them to biopsy. But you can absolutely send to ENT too, and this is within their scope.
Thank you.
Thanks for a really good question. Sorry I didn't bring that up sooner.
And I'll just add to that a little bit because it often comes, many of our patients have Medicaid, and we will sometimes want a biopsy, and we have to decide between which would be more efficient, referring to them to oral surgery or ENT. And we have the same conversation. They often don't have any other dental coverage except Medicaid, and Medicaid requires them to have a PCP referral to see ENT or to see any specialist. So it's actually quicker for them to go see their PCP first before going to ENT. So if you had a patient in your office as a primary care or non-dental provider, it might actually be both financially and just as far as navigating the system, it might actually be more efficient to get them through to ENT or some other medical provider versus trying to go to oral surgery. It's weird, doesn't make any sense, but that's just kind of how it is here in Idaho.
Another note about biopsies as well. Sometimes those biopsies can be done therapeutically also. So we get a fair number of biopsies sent to us as periodontists, and we do things like, for example, fibromas that might have appeared on the tongue or on the lip, bumps on the gums that are bothersome to the tongue, or things along those lines. We always, whenever we remove something, we always send it in for a biopsy, a pathology report, so we know exactly what the entity was. But that is something else to look out for. Even if it doesn't involve the patient, it's not changing. But if it's aesthetically or bothersome to the patient, it could be considered to have that sent over for a biopsy regardless.
And I see a question about time interval between like an extraction and general surgical procedure. To my knowledge, there aren't any like specific like guidelines from organizations, and I think it may actually just depend on like clinician comfort. I think this comes up a lot where there actually are recommendations for oncology specifically that if someone's going to get head radiation for head and neck cancer, they need to have extractions before they can get that. And it's like a literal barrier to getting that treatment. And so I think they often recommend a wait time of at least 2 to 4 weeks before they start after extractions before radiation starts. And a lot of that's because radiation is so damaging to tissue and makes it harder to heal. But for general surgery, I'm actually not sure. I would be curious what surgeons say. I would imagine to a certain extent, it depends on how risk averse they are.
Okay, thank you. We still have a few minutes if anyone else has other questions or thoughts on what we've discussed today.
This is Melody. I had a rural clinic, kind of long drive for people to go if they could put gas in their car and that sort of thing. And um, I guess I think that you gave a lot of good pointers today about one being able to recognize some things, and we didn't have X-ray. I had to do a presentation in the next closest city and show them what I had to even look at. We didn't have digital films, right? The old view box thing, and they were like, "Oh my God." Anyway, so I think a lot of what you shared today is really helpful for those people that may be in places where there isn't anybody. I mean, we didn't have a dentist in our community at all. And so I love the idea of being able to shadow a dentist for a bit to learn how to just even numb up the tooth, and get better reception for how you would do pain management for those things. Because the community that I practice in, we had no fluoridated water at all. It was all well water. So everybody, not just the kids, but everybody had horrible teeth, if they grew up in that community. So we saw a lot of really significant dental problems. So I appreciate a lot of what you shared today.
Thanks, Melody, and thanks for sharing your story.
It looks like someone added a comment in the chat. Diabetes and periodontal disease have a strong correlation. So, our panel have any thoughts on that? Or presenter?
Yes, that is true. There is very mixed evidence whether treating periodontal disease actually improves your diabetes, and I think the jury is kind of set to no, but that doesn't negate the fact that it's important to treat your periodontal disease because periodontal disease is bad and people deserve to be pain-free and have teeth.
Great. Thank you, everyone. So before I close us out, I do want to thank Jennifer Wheeler for being here with us. She is from the Idaho Oral Health Alliance, and well, I'd like to give you a couple minutes if you'd like to kind of help us close out too.
Thanks, Jocelyn, and thanks everyone. The idea of medical dental collaboration and oral health integration into primary care has been a theme of the Oral Health Alliance since early 2000s. We know that all of you as medical providers have a significant to-do list when your patient's in front of you, and we realize that we're asking you to do more, but we also have the resources to help. We can help you with adding questions to your check-in paperwork. We can come to your clinics to do some trainings for you on fluoride varnish and some other things. And we have web resources for you, and we have a really wonderful panel that they're dedicated to helping all of you. So thank you so much for your time, and we really hope you'll join us next month. And thanks to Echo Idaho for doing this. It's a thrill for all of us. Thanks.